So hand and wrist examination, there are lots of things. So I'll go through a lot of pathology. But what we want to do is we'll revise a few little important things. I want you to go home with at least 5 points, because hopefully I'm talking to you about 100 points, but hopefully each of you will go home with at least 5 points. So what are our plans today? We are going to learn a little bit of anatomy, basic science. We are looking at a few things on examination, and we are going to look over many conditions and how to diagnose them and some of the treatment modalities for them. So it's a refresher on hand and wrist MSK pathology. So the conditions that we are going to look at is carpal tunnel syndrome, D. Quervain Tenosynovitis, trigger finger, wrist instability, post-traumatic wrist arthritis, psoriatic or rheumatoid arthritis, Dupuytren's contracture, mallet finger, Garrod's pads, jersey finger, ape hand deformity, bishop's hand, claw fingers, wrist drop deformity, and a little bit on fractures also. So the bones in the hand, you have in the forearm, you have the radius and the ulna. Then you have the carpal bones. There are 8 little carpal bones. Then you have the metacarpals, and then you have the phalanges. Now, usual places of arthritis are in this part, the radiocarpal joint, and also in the first carpometacarpal joint. That is the usual site of arthritis. You may get arthritis in the MCP, PD and a PIP and the DIP also. So that's where the usual areas of potential surgical interest. Now, it is important to earmark or landmark the different bones, because in case you need and to give an injection, the easiest way to identify the wrist joint is to find the Lister's tubercle. So if you feel the dorsum of your wrist, just not where the gap is, but just ahead of it, you will see a very prominent little bone, and that's the Lister's tubercle. Just distal to that is a small depression, and it's in that depression you have the wrist joint in case you have to give an injection into the wrist joint. Then you have the anatomical snuff box, which is between the extensor pollicis longus and the first extensor compartment, and that on the base of it is the scaphoid, and usually it is a bone that is injured, or there may be a suspicion of an injury, and because of the potential for avascular necrosis and later arthritis, that is why it is important to recognize the fracture of the scaphoid. I don't want to go through all the muscles, but I want you to understand there are 2 different groups of muscles. I mean, there is flexors on the volar side and extensors on the dorsal side. But more importantly, I want you to recognize there are extrinsic hand muscles and intrinsic hand muscles. So extrinsic hand muscles are muscles that start in the forearm and reach the hand. So they are the powerful muscles. So the extensor digitorum, extensor pollicis longus, extensor brevis, flexor digitorum superficialis, flexor digitorum profundus, all start from the forearm, and they are able to, and that is how we can get a tight grip. If you're lifting a suitcase or holding a dumbbell tight, these are the muscles that are acting and holding, allowing us to grasp the object. So those are the extrinsic muscles. But the intrinsic muscles are the smaller muscles in the hand which do the finer movements and stabilize the joint. So that is the function of the intrinsic muscles. So it is a balance between the intrinsic and the extrinsic muscles that allow us to make all the movements and the fine motor activity that is possible with our hands and fingers. The nerve supply, you have all the 3 nerves, the ulnar nerve, the median nerve, and the radial nerve. On the dorsum of the hand, on the radial part where the thumb, the little bits of the index, middle, and a little bit of the ring finger, you have the radial nerve. The 1.5 digits on the near the little finger and the ring finger is the ulnar nerve, and that is basically both on the volar aspect and the dorsal aspect. And coming to the palmar aspect, the 3.5 fingers, that is the thumb, the index, and the middle finger, and half of the ring finger is the median nerve. So all the 3 nerves supply the hand, and maybe if there is an injury to the nerve, that particular area, you will have hypoesthesia or anesthesia. The blood supply, there are two arches, so even if one the radial artery is lost, you will still get it from the ulnar artery, and inside there's a deep palmar arch and there's a superficial palmar arch, and the branches from that go to different parts or go to the fingers. Yeah. The joint, the wrist joint, the carpometacarpal joint are opposition. There is ability to take the thumb and touch the tip of all the other fingers. That is one of the greatest, progress, evolutionary progress that we have made, and that has allowed us to be very dexterous, small, fine motor activity, small screwdriver. Yes, apes can do a little bit of that, but not as well as we can do. Apes can, hold on to nuts and put them into their mouth, but we have much more finer control on it. But in any examination, you need to look, feel, and move. Or, in other words, sometimes it is look, move, and feel. Feel may be the last thing that you need to do because it may cause pain, and you want to test the range of motion. So one of the easiest ways is to make a fist and extend it. And in the distal interphalangeal joint, you may have about 0 to 80. In the proximal interphalangeal joint, you have 0 to 100. And in the MCP joint, there where the metacarpophalangeal joint, it is from 0 to 40 degrees, or sometimes 0 to 90 degrees if it is in full flexion. But the way to look supination and pronation is to ask them to put their thumb out and then turn the hand outwards and turn the hand inwards. That gives you a better idea. If the thumb is folded inwards, you may not be able to appreciate that it goes the full 180 degrees. But as I said, the thumb is very important, and we have different grips. We have the end pinch, like how you will hold a pen, or you can have a side pinch on how you'll hold a key, or you'll have a chuck pinch on how you will tighten a chuck. All the three fingers, the thumb and the index and the middle, are involved. But this is the main movement in the wrist. This is the dart throwing plane. So in a dart throwing plane, the hand is in a radial deviation and extension at the beginning, and it ends in ulnar deviation and palmar flexion. So that movement is one of the very common movements that we do with our wrist. So hence the dart throwing, this is called the dart thrower's plane, and that movement should be good and for our wrist to function very well. But it is important for us to note whether there is any atrophy. You can see in this hand, you can see the thenar eminence is atrophied. So that means the muscle supply is less. This can be from two reasons in the thenar. It could be from the median nerve, or it's also possible from the ulnar nerve, because the adductor pollicis is also in the thenar group of muscles. So we'll come to that. So there are some special tests. One of the commonest tests applied is the Phalen's maneuver. The Phalen's maneuver is to find out whether there is carpal tunnel syndrome. You can do a direct compression of the carpal tunnel, but this is a better way. You ask the patient to fold both the wrists at, say, at 90 degrees, and that way you're increasing the pressure of the median nerve. And if the person has carpal tunnel syndrome, then obviously the symptoms are, you can recreate the symptoms. That is pins and needles into the 3.5 digits. That is the thumb, index, middle finger, and the ring finger. So you'll recreate the pins and needles in that. You can also do a reverse phalanx, not as good as the normal phalanx. That is, you hold the thumb like this, as if in the position of prayer. And again, there is some compression, but the other way, that is more easier, more sensitive than the reverse phalanx or the prayers test. Tinel sign. Now, that is again another sign which is important in recognizing if there is demyelination. Demyelination is these nerves have have an insulation, a covering over them. But unfortunately, if there is some damage to the nerve, that covering goes away. So in the carpal tunnel syndrome, when you get carpal tunnel, there's pins and needles in the 3.5 fingers. That part, the nerve in this area, loses its myelin sheath, so it becomes unmyelinated. So that is why if you tap over that, you will get electrical shocks going into the hand. That is because of the compression. It has lost its insulation, and the nerve becomes more vulnerable or more excitable, that when you tap on it, you can feel these electrical impulses going into the same 3.5 digits in your hand. Froment sign. Froment sign is a sign to identify when ulnar nerve is damaged. So in a normal person, if you give them a card to hold the card and you pull the card away, they will be able to hold without flexing the IP joint of the thumb, because their adductor pollicis is so strong that it can hold the card without it being slipping. But unfortunately, if you have lost that adductor, then you have to use your flexor pollicis longus. And when you use your flexor pollicis longus, there will also be flexion at the IP joint. So that is how Froment's test, someone who's got an ulnar nerve palsy, when they are not able to just grasp the paper with just their thumb and the index finger, they will need to bend their thumb. There is something called the OK sign. That is the anterior introsseous, part of the median nerve, but it's a only a motor nerve. And when that supplies the pronator quadratus, flexor pollicis longus, and flexor digitorum profundus. Now, if that is damaged, we won't be able to do a perfect O like this. And what will happen is you can only opposite side to side, but not tip to tip. Tip to tip. So if you are able to oppose it tip to tip, then the anterior introsseous nerve is working. That is one of the signs. Now, wrinkle test. Now, if you dip your hand, sometimes when you get into a shower or if you're in the swimming pool for a long time, you will find that your fingers and toes wrinkle like what is shown in the image. That is because some of the cold water causes the vessels to contract. And because the vessels are contracting, there is less tissue edema there, and that is why it is wrinkling. Normally, there is tissue fluid, but because of the vasoconstriction. But that will only work, the vasoconstriction will only work if there is nerve supply. Otherwise, it cannot, because for the sympathetic to work, it has to bring the nerve supply. So if wrinkling doesn't happen, it is a sign that there may be nerve damage to that finger. Allen's test is to see the patency of the radial and ulnar artery. I said there are two arteries, but before, say, suppose there is an injury and you want to test whether the other artery is present or not. This is the way you test it. You clench the fist, and by clenching the fist, you're letting out the blood supply from the hand completely. Then you press both the radial and ulnar arteries, and then you sequentially release them. So once you release this, and if it fills up quickly, you know the ulnar artery is intact. Similarly, again make a fist, clench it, hold it here, leave the radial artery, and if the hand becomes reperfused, then you know the radial artery is intact. So it's a blanching and reperfusion of the hand that you're looking at. Now, there is something called the sweater finger or jersey test. Happens in footballers or other. So there is a tendency for when you're chasing the ball, someone is having the ball, you're running behind them. There is a tendency for you to grab hold of the person who's running ahead with the ball. And when that happens, there is a sudden pull on it usually happens in the ring finger, and the flexor digitorum profundus is affected, and then they won't be able to flex at the DIP. I've got another image later on, a better image, which will show you that. So that is a sweater finger, because you're trying to hold the jersey of the person who's ahead of you. Bunnell's Littler test. So again, sometimes when you have a fracture or any injury and there is swelling in the hand, then there may be, or you have put a plaster for too long in the wrong position, the intrinsic muscles get contracted. If the intrinsic muscles get contracted, so if you're an extension like this, you won't be able to flex the first PIP joint. Whereas as soon as you flex it at the MCP joint, because what happens is the lumbricals, this is the lumbricals here. The lumbricals, the duty of the lumbricals is to flex the MCP and extend the PIP and the DIP. But if it is contracted because of the wrong plaster having been put on the hand, because the hand immobilization, we should be very careful. If you put in a plaster for more than 10 days in the wrong type of plaster, there can be permanent contractures. Even as short as 10 days can cause permanent contractures. And one of the muscles that is involved is the lumbrical. So it's always important that when you're using a plaster, the MCP joint is kept at 90 degrees and the IP and the DIP are kept extended. Otherwise, it is likely that you will have this lumbrical contracture. So now looking at the carpal tunnel syndrome. So this is the median nerve that is involved. So the median nerve comes underneath the flexor retinaculum here. So this is the volar aspect or the palmar aspect of the hand. So this is the median nerve coming underneath the flexor retinaculum, and it supplies the 3.5 fingers. The usual, and so there is a pressure in the median nerve. So anything that can increase the swelling here, if there is more fluid here. So in rheumatoid arthritis, sometimes in diabetes, sometimes in pregnancy, there is increased fluid. Sometimes with repetitive tasks using the mouse, I get it when I cycle and I keep my hand on the handlebar because of the pressure I get. So after a certain time, I have to keep shaking my hands while I cycle. But otherwise, I never have carpal tunnel syndrome, but only when I'm cycling because of the pressure on the median nerve because of the position of cycling. So it's the compression of the median nerve. It is quite common. It's up to in 4% of the adults. Now they say you need to do nerve conduction studies, but that is not necessary. A good clinical diagnosis is good enough. It's as good as electrodiagnosis, and you'll have paresthesia in the thumb, index, and the middle finger. And the symptoms are worse at night. Why is it worse at night? Because at night our body fluid gets redistributed. During the day, the excess fluid is in our legs, and that is why sometimes if you sit on a flight for long, you will find that you will have some pitting edema in your legs. But at night, as you're lying down, that excess fluid in the legs is redistributed to the rest of the body. And when it is redistributed, there is more fluid in your hands, and that is why you get carpal tunnel syndrome. And you wake up at 2 a.m. or 3 a.m., rub your hand, and then once the swelling goes off, you're able to get back to bed. So that is why it happens. So this is the 3.5 fingers that are involved. Sometimes again for the median nerve, you want to check whether the abductor pollicis brevis, but this is in an acute carpal tunnel. So sometimes when a distal radial fracture you have, there can be swelling within the carpal tunnel, and that can put a pressure on the median nerve, and you can get an acute carpal tunnel. But in an acute situation, it is likely that the patient, I mean, elevation may help, but you may require surgical intervention. So there are many ways of identifying. We looked at the Phalen's test. We also looked at the Tinel's test. Tinel's test is, as I said, percussion. Phalen's test is keeping the wrist flex. But you can also do the Durkin test. Durkin test is take the thumb and directly compress over the median nerve. Keep it for 60 seconds. And if it is replicated, then you know. If the pins and needles is replicated, then you know that there is carpal tunnel syndrome. And the 2-point discrimination. So you take an office clip, open it out, and keep the ends to up to 5 millimeters. So when you touch the tips of your fingers, you should feel it as 2 points. That's a 2-point discrimination. When you have carpal tunnel syndrome, in those 3.5 fingers, you will lose that. At 5 millimeter separation of the 2 points of the paper clip, you will not be able to recognize it as two different points. You will think it is only 1 point, and the 2-point discrimination is lost. But majority of carpal tunnel syndrome can be treated non-operatively, but it is very important that we are keeping a straight wrist splint. Now, usually what happens is patients are given a futuro splint, but the futuro splint is kept in a bit of extension because keeping it completely straight is not a functional position. You can also try squeezing your fingers with one hand. So take the 2 fingers of one hand, put it into the palm of the other hand, and squeeze those 2 fingers. And you will notice that you get maximum pressure when the wrist is a bit extended rather than it is flexed. If it is flexed, you will notice that you're not able to give the power. So same way when you're lifting a suitcase, you will realize it is an extension. So keeping it in neutral is not an efficient position. And so that is why these neutral spin patients don't like to wear it during the day. So it's important. And because the symptoms are only at night, you advise the patient to wear the splint at night, and keeping it in neutral will allow there won't be pins and needles, and it won't disturb your sleep. So a neutral splint is good enough to treat the carpal tunnel syndrome. Occasionally, however, that may not solve the problem, and you may need to give a steroid injection. That will also potentially provide, and 80% of the patients with a steroid injection have good benefit. But it's important that you're giving a soluble steroid and not a steroid that, long lasting steroid, because you don't want that to be there for a long period. So water soluble steroids are better than long lasting steroids. So not the normal steroid that you give into the joints are not given into the carpal tunnel. But if that doesn't solve, then you have to decompress and you have to take away the flexor retinaculum. It's a small incision, and then you identify the flexor retinaculum and then release it. The next condition we look at is D. Quervain tenosynovitis. Now, D. Quervain tenosynovitis is from the first compartment. So there are two tendons there, the abductor pollicis longus and the extensor pollicis brevis. Both of them come through the first compartment, and sometimes repeated wrist radial deviation is what can cause it. So there will be swelling on the thumb, and usually it is on the just on the radial side. I'll show you another diagram later on where there is swelling. It is also called the mummy's thumb, because young mothers who have little babies tend to hold their babies by their arms, by their chest, in their armpits, and lift them. And that is the common position. And repeatedly, suddenly lifting. You have a new baby, you're lifting for a year, the baby as, and then that can cause inflammation in the extensor pollicis brevis and the abductor pollicis longus, and that is what happens in D. Quervains. So again, modification of activity, having a wrist splint, or sometimes even an injection may be necessary for identifying it. In the physical examination, you will have tenderness in the first dorsal compartment. It's 1 to 2 centimeters before the radial styloid. There is a Finkelstein's test. I've got an image later which you can see, and the splinting or injection. Some very rarely you will need a surgical release. So this is the Finkelstein's test. So you hold the thumb and push it into the palm of the hand, and if that reproduces the symptoms, then you know that there is D. Quervain tenosynovitis. Or you can use the Eickhoff maneuver. The Eickhoff maneuver is ask the patient to grasp the thumb as shown in the top image, and then ask them to ulnar deviate the hand. And when that causes increased pain in the dorsal, in the just proximal to the radial styloid, then you know there is D. Quervain tenosynovitis. Yes, one of the options, if activity modification, and usually mothers, they, as I said, there's mummy's thumb, so activity modification, ask them to lift it in another way, or even resting it a bit and not to lift too many times will potentially solve the problem. If not, you can give a steroid injection. But when we give the steroid injection, it's important not to give into the tendon and only outside, because if you give it into the tendon, it may cause a tendon rupture. So you put the needle in, ask the patient to move the thumb. If the thumb is moving, then it is in the tendon. So you have to move, manipulate the tip of the needle so that it is not in the tendon but just outside the tendon, and then you slowly inject the steroid in local anesthetic, and hopefully that will settle the inflammation. There is another similar syndrome called the intersection syndrome. So it is like this. So when you have pain just here, that is D. Quervain's tenosynovitis. But you have symptoms here, it is a distal intersection. So in the hand, you will notice these are the two which will cause D. Quervain's, but they come from outside to inside, whereas the extensor carpi radialis brevis and extensor carpi radialis longus come from inside and go outside. So here they are intersecting. So repeated activities, so electricians, people who screw items a lot, they may get this, and they will have pain in this area here. That is the intersection. So depending on the tenderness, whether the tenderness is just proximal to the radial styloid or whether it is in the dorsum of the radius, then you decide whether it's a D. Quervain's or the intersection. Usually splint and activity modification should solve the problem. If not, we can give a small steroid injection. Trigger finger. Now there are so many tendons in the hand. They, as I said, we are dexterous. We can, our dexterity, so fine motor movements are possible. But because to hold those fine motor movements, we need a lot of pulley system, and we have a pulley here near the MCP joint, which allows the flexion and the movement of the tendons and movement of the fingers. But unfortunately, sometimes there may be a myxomatous degeneration in that tendon, and there may be a swelling. When there is a swelling, there is what happens is you get a trigger finger, the swelling comes through and then it doesn't go back, and the tendon, the ring is caught. So it is the A1 pulley. That pulley is the A1 pulley. There's a lifetime incidence of 2% and usually occurs in the age of 55 to 60 years of age. That's when it usually occurs. And again, a splint will help, activity modification will help, and you will find a palpable nodule in the flexor digitorum superficialis tendon, and you may get a popping sensation when they make a fist and straighten it out. So this is what is a trigger. The patient has made a fist. All the other fingers have gone forward, but you can see that the middle finger is kept in the flex position and the patient cannot. And then suddenly it will flick it out into place, and that is why it's called a trigger finger. So activity modification is splinting. So you have to immobilize the MCP joint. I'm showing you a picture later, or a surgical treatment. You release the A1 pulley, and usually 80% of the patient's symptoms improve with one steroid injection. So this is the splint that you use for trigger finger, so that the patient, you don't allow the patient to flex the MCP joint, but flex at the PIP joint and the DIP joint, and that should be, make the movement okay. And again, sometimes we may give a steroid injection. Again, hit it, go see, feel where the tendon is. Put a small, it should be a 23 or a 24 gauge needle. Inject it, and again, usually a soluble steroid. See that once the needle is in position, ask the patient to move the finger so that you can know that it is in the tendon sheath and not inside the tendon, because you shouldn't inject into the tendon, and a little bit of injection is enough, and it'll decrease the swelling and the patient will be able to move, not immediately. This is a bit of a complex topic. This is the instability in the wrist. So I don't know whether you've heard of what is known as DISI and VISI. So DISI and VISI is dorsal intercalated segmental instability, and VISI is volar intercalated segmental instability. Let me explain to you. So this is the seesaw. We have all played on the seesaw when we were young. We were sitting on one side, our friend, was sitting on the other side. We had to go up, they would come down, then they would go up, and we would come down. In our wrist, it is a similar seesaw. The three parts, so there is a fulcrum, there's someone sitting here and someone sitting here. And that is exactly what happens in the wrist. It's like a seesaw. Scaphoid is at one end, the triquetrum is on the other end, and the lunate is the fulcrum in the middle. So when the scaphoid volar flex, the same movement is transmitted, but the triquetrum prevents it from moving. So there is a bit of a break on it. Same way, when the other way around, there is a break by the scaphoid. But unfortunately, the ligaments between the scaphoid and the lunate can get ruptured, or the ligaments between the lunate and the triquetrum can get ruptured. So if these ligaments get ruptured, it is called DISI. If these ligaments get ruptured, it is called VISI. Let me explain it a bit more. So this is how the wrist moves. So you can see this is the lunate and this is the scaphoid, and that is how it normally moves on the lateral picture. But as I said, if this ligament is damaged, then you will get DISI, or dorsal intercalated segmental instability. When this ligament is damaged, you get volar intercalated segmental instability. Now, having a sprain of the wrist, falling onto the outstretched arm is very common. The elderly patients, they have fracture of the distal radius, that is a fracture here. But in youngsters, we always worry that they have damaged the scaphoid. And the scaphoid, this part of the scaphoid doesn't have very good blood supply. Usually all bones have blood supply from both ends, but in the scaphoid, there is only blood supply from this end. So this end doesn't have blood supply. So that is why if there is a fracture, there may be avascular necrosis. So that is why we need to, keep them in a cast, even if only there is a suspicion, and then re-x-ray them again. But sometimes you fall on the wrist, you don't see a fracture, but they still continue to have pain. It is possible they have this ligamentous injury, the dorsal intercalated segmental injury, and these ligaments are gone. And that is why that instability occurs. So as I showed you, if normally it's like a nice seesaw. All the three of them work together. But if there is a damage to the ligament between the scaphoid and the lunate, that is here, then the lunate is trying to move much more with the triquetrum. There is no break from the scaphoid. Equally, if the ligament between the lunate and the triquetrum is damaged, then the scaphoid and lunate move together, and the triquetrum, it moves independently. It's not like a seesaw anymore. So this damage here is called DISI. This damage here is called VISI. So this is what happens on the side. So in a normal, you should maintain the lunate and the scaphoid angle, but you can, sorry, capitate angle, but you can see the angle changing when there is a DISI or a VISI deformity. To identify the DISI, you do what is known as the Kirk-Watson test. So you hold with one hand the radius. So this finger is stabilizing the scaphoid. And with the other hand, you're moving from a radial direction, from an ulnar direction to a radial direction. So you're pushing it into ulnar deviation, then pushing into radial deviation. You will feel a click there, and a painful click suggests that there is scapholunate ligament is lost. But the easy way, another way to identify is looking at an X-ray. Because that ligament is lost, the scaphoid moves this way and the lunate moves this way, and there is an increased gap between the scaphoid and the lunate. And that increased gap is called as a Terry Thomas sign. So Terry Thomas was a comedian many years ago, and he had front teeth. There was a gap between the front teeth, and that was his characteristic symbol. And same, that is why we have this name as the Terry Thomas sign, meaning the lunate and the scaphoid have separated, and there is a gap there, and that is a VISI deformity. You can also do a lunotriquetral share, or the Reagan's test. This you're seeing whether the lunate and the triquetrum, those ligaments are damaged, but this is a much less of an injury as possible. But then what happens if there is this injury and you miss it? Then there is advanced arthritis. So in the wrist, you can have SLAC and SNAC, and I'll explain that to you. So this is a SLAC, scapholunate advanced collapse, whereby there was an injury to the wrist. It was only a sprain. There was no scaphoid fracture, but this ligament was disrupted. When this ligament is disrupted, the capitate starts to grind through that gap, and then there is arthritis that sets in. And because it is scapholunate is the cause of the problem, it's called scapholunate advanced collapse, and there is this arthritis in the wrist now. The alternate form is the scaphoid SNAC, or the scaphoid non-union advanced collapse. Here, there is a fracture of the scaphoid, as you can see here, that is not united. And because it is not united, this may go into avascular necrosis, but you can see the earlier signs of arthritis between the distal pole of the scaphoid and the tip of the radius. So this is a SNAC. Also, obviously, just normally you can get arthritis, but usual primary osteoarthritis is more common in the hip and the knee and in the fingertips rather than in the wrist. But you can get arthritis in the radiocarpal joints. Sometimes you may get arthritis in the distal radioulnar joint, but that may be from trauma. I don't know whether you can recognize this patient had a fracture at a very young age, and you can see a slight bend in the distal radius, and that is how there is arthritis in the distal radioulnar joint. Yeah. So SLAC is the most common form. You need to get X-rays, and to avoid SLAC, you need to be aware that is there a previous history of scaphoid fracture or wrist injury, and that is when we will identify. So you may have wrist pain, there'll be morning stiffness, decreased range of motion, and decreased strength in the hand. Yeah. And when you inspect any arthritis, you see the normal, sometimes it is a normal appearance, sometimes it is severe deformity. And you need to palpate to identify where exactly is the maximum tenderness. Now, if it's the distal radioulnar joint, the piano key test, meaning pushing down on the ulna, will cause pain, and also there'll be an abnormal movement, and also a shock test. You can move it out of place, and you can perform the Watson's maneuver, which I told earlier, where from ulnar deviation you push it into radial, and you will hear a small click. You don't need to know all this, is too much of information. Yeah. So treatment is non-steroidal anti-inflammatory drugs, lifestyle modification, wrist brace, or you can give ultrasound or fluoroscopically guided, steroid injection into the joint. Now, this I want, so here this is a patient who has a wrist arthritis from an earlier injury many, many, many years ago. And you can see he doesn't move the right wrist very comfortably. And when you take an X-ray, you can see that there is a scaphoid non-union, and that is why there is a SNAC. It's a SNAC wrist where there is arthritis, whereas the lunate is intact. It is not the problem between the lunate and the scaphoid. This is psoriatic arthritis. You can see the scaly patches on the elbow. So psoriasis is an autoimmune disorder. It affects the skin, but can also affect the joints. So when it affects the joints, it usually affects the nail. You can see the nail bed also is affected. And in the joints, you may have psoriatic arthritis and dactylitis. The whole finger is affected. So that's from psoriatic arthropathy. You may have osteophytes, destruction of the joint. Yeah, and these are the different signs that you can see in psoriasis. In rheumatoid arthritis, we nowadays don't see such grotesque deformities because we have monoclonal antibodies, immune therapy has come in, and hence people are, it's good news and people are not getting these deformities. In my younger days, I would see a lot of these deformities, much less of these deformities now. So the swan neck deformity is again when there is the dislocation at the PIP and hyperflexion at the DIP joint. It looks like a swan, so that's why it's called a swan neck deformity. And then you have a boutonniere deformity where the central slip is ruptured. So at the PIP, it comes more dorsally, and you will not be able to straighten the fingers. So that's a boutonniere deformity. Again, occurs in more common in rheumatoid arthritis. But in rheumatoid arthritis, one of the things that we can see is the ulnar shift. The fingers of the hand move actually towards the ulnar side, and that is because of a imbalance between the tendons and the ligaments, and that is why you get the ulnar drift. But in hand arthritis, the rheumatoid arthritis usually affects the MCP joint and the proximal interphalangeal joint, whereas osteoarthritis usually affect the distal interphalangeal joint and the proximal interphalangeal. They usually don't affect the MCP joint. So this is rheumatoid arthritis. You can see the ulnar drift on the right hand. You can see the swelling and synovitis in the MCP joint. You may also get in rheumatoid arthritis rheumatoid nodules like this. It usually on the extensor aspect, on the dorsal aspect of the fingers also, rheumatoid nodules. But this is primary osteoarthritis in the hand, and that is called by the Herberden's or Bouchard's node. So the Herberden's node are where there is osteoarthritis in the DIP joint, and the Bouchard's node is when there is osteoarthritis in the proximal interphalangeal joint. So the primary osteo, and sometimes it is not symptomatic. Patients get along very well, and they don't need any treatment. But sometimes they may have difficulty. But again, the amount of treatment that you can give other than supportive exercises, exercises does help by taking away their pain. If you have arthritis in the CMC joint in the hand, we can give some steroid injections. This is the first CMC joint arthritis, occurs quite commonly. So this is the trapezium and this is the first metacarpal, and you can have arthritis there. And so exercises do help on the hand. And number two, you may give a steroid injection, or lastly, and you can give a trapezectomy. So here you're trying an axial load and grind, and they will have pain, or in thumb metacarpal joint, you're adducting it, that will also create pain in that joint. So one of the methods, surgical methods of treatment is the flexa carpi radialis. You take a little bit of the tendon, not the whole tendon, so that most of the tendon is still working, but you take a little bit of the tendon, bunch it up all together, and keep it in that place where you have taken the trapezium off, and then it hangs as a a joint, a false joint there, and you can have reasonable range of motion. Dupuytren's contracture. So this is a classical case of a Dupuytren's contracture where the palmar fascia, there is fibroblast and excessive fibroblast causes contraction of the MCP joint and the PIP. Very rarely is the DIP or the distal interphalangeal joint involved. It's usually the proximal interphalangeal joint and the MCP, and you can see a fibrous band going, usually seen in men in the ages of 50 to 70, and it's seen also in the ring finger or the little finger is the usual sites. But if they are able to place the hand flat on the table and there is only Dupuytren's nodule, nothing needs to be done. When they can't place the hand flat on the table, that is when you may need surgical intervention or any other intervention. Now, there was a very good injection, collagenase injection, which could be given, injected directly into the fibrous band, and that would just dissolve the fibrous band. But unfortunately, it's just gone out of the market, and I really don't know why it has gone out of the market. No one seems to know. A good drug company was marketing it, but suddenly they completely withdrawn. I don't know whether they had any litigation against them or whether they had any information, but it was a good thing to have for Dupuytren's contracture. And otherwise, the only other solution is doing a surgical intervention and removing. And unfortunately, there's still a significant chance of recurrence. But some of the, you can do a McCash technique where you keep it open, then the chance of recurrence becomes less. A common injury is a mallet finger. A mallet finger occurs because the extensor digitorum gets attached to the distal phalanx and it may rupture off. So it can happen, when anything that causes a forced flexion. So you're putting your hand into the sleeve of your shirt, your tip of a finger catches on the edge of the sleeve, and it suddenly, as you're forcefully pushing it in, you suddenly flex your finger, and that is when the ligament, the tendon breaks away with a small piece of bone. But again, it doesn't need any surgical intervention. Putting a splint like this for 6 weeks or sometimes even for 12 weeks will help it. But then the important thing is when you remove the splint, you have to see that the finger, you can change, the patient is allowed to change the splint every day, wash the splint, but whenever you're changing, you should not allow it to flex back itself, because then it's not going to heal. You have to keep it in the extended position while they are changing. This is known as Garrod spats. Sometimes it is seen in association with Dupuytren's, but otherwise it is quite, occasionally you see it, but this has no significance, no pathological significance. It just appears and it is there. It may be slightly not cosmetically not very good, but otherwise causes no functional limitation at all. We looked at the jersey finger. I said that when someone is trying to catch, there's a tendency to catch the player in front of you, and then you rupture the flexor digitorum profundus. So that's why you can't flex at the DIP joint. So in this, it's the ring finger that is usually affected, and you can't flex at the DIP joint, and it remains extended. So this is the way you test the flexor digitorum profundus. So you have to stabilize the middle phalanx and ask the patient to flex the distal phalanx. If they're able to do that, then the flexor digitorum profundus is intact. Whereas to test the superficialis, they need to be able to flex the proximal interphalangeal joint. So you have to prevent the other fingers from being flexed, because you have to negate the effect of the flexor digitorum profundus. So that's why you keep one hand and keep the other fingers straight. So here only the flexor digitorum superficialis is working. So this is the connection. The flexor digitorum profundus comes from deep inside, goes between the slips of the FDS and attaches to the distal phalanx, whereas the flexor digitorum superficialis splits around the FDP and attaches into the middle phalanx. But the lumbricals come like this, and that is the lumbricals is what causes the flexion of the MCP joint and extension of the IP and the DIP joint. So they work together. So looking at some of the nerve problems, so when the median nerve is affected, you have what is known as the ape hand deformity, because you're not able to approximate the thumb to the other fingers. And there will be wasting of the thenar eminence, and you're not able to oppose or flex the thumb. This is again a similar where there is But this is a different, where there's an ulnar claw hand, where it's only the little and ring fingers are flexed, and that is because the overaction of the flexor digitorum profundus and the lack of action of the lumbricals. The lumbricals is what flexes at the MCP joint and extends the IP. So the lumbricals are not working here. But sometimes you can have both and here again the ulnar nerve is damaged, and when the adductor hallucis is affected, you will have wasting of the first web space. So the first web space, both by median nerve and ulnar nerve, can cause it. This again is a patient who can see he's got a Benedict's hand. That is as if a blessing hand. You're flexing your little finger and your ring finger. The other fingers are straight. That's called the Benedict's hand. And that can come from the ulnar nerve palsy. Now, this patient, you can see, has got a significant valgus angle. It's got the same deformity in the hand, but that was because he has a lateral epicondyle fracture. So the ulnar nerve coming like this, there's a tardy ulnar nerve palsy. So it's been stretched, and that is why he's got an ulnar nerve palsy on that side. So this is a claw hand or a claw fingers where both the median and ulnar nerve are affected. So there is clawing of all the fingers. This clawing is on the ulnar nerve. These two clawing are from the median nerve, and there is significant clawing of the entire hand, and that is a claw hand where both combined median and ulnar nerve palsy has been affected. Yeah. Radial wrist drop is very common in people who sleep maybe on a chair or something. It's called the Saturday night palsy. You've gone out for a drink, you come back, there is no place to sleep on the bed, you stay on the chair, and your hand is hanging over the arm of the chair, and next day morning you'll find that you're not able to lift your wrist up, and that's because, but again, it recovers within 90 days, sometimes even much less. How to identify whether there is nerve injury in the hand. And even in children, you can use the same trick in children or in adults also. So you should, the game rock, paper, scissors, okay. So if the child is able to rock, paper, scissors, the usual game. So rock, paper, you ask the child to do the paper, and if the paper is able to do that image, then the radial nerve is intact. Rock is making a fist, and if the child is able, or the adult is able to do a rock, then the median nerve is intact. Then scissors, the action of abduction and adduction, if that is intact, then the ulnar nerve. And if you can do the okay, the anterior interosseous nerve is also okay. So rock, paper, scissors, one of the common children's game, can be used for identifying whether there is any nerve injury, and you can identify all the nerves to the hand. You can identify. Coming to the fractures, one of the common fractures, the boxer's fracture, where someone hits an unintended object or is very strong. You're supposed to box with these two. These are the stronger bones, but sometimes in hesitation box, you hit the little finger, and that's how you have a fracture of the neck of the fifth metacarpal. You can see there is a angulated fracture there. And also you can have a scaphoid falling onto the wrist. You can have a scaphoid fracture. And this, as I said, there is an increased chance of avascular necrosis. So you need to immobilize it. Colles fracture, very common in the elderly, and we'll talk a little bit about Colles fracture. You can have dislocations. If you see something like this, you want to relocate it as quickly as possible. There's no harm done in relocation. Trying to align the limb in the normal position is not going to cause any further harm. So try to, because that will also restore the blood supply if the blood supply is kinked. The distal radial fractures can be called by different names. This is the classical Colles here. Then you have the Smith's volar. When part of the joint is involved is a Barton's. Then you can have the radial head, the styloid, which is the Schauffers. You can have a lunate fossa or a die punch fracture. But the commonest is the Colles fracture. So this is a distal radial Colles type of fracture, comminuted, and you can see here there is a deformity, and this patient was left to heal in this deformity. You can see the same dinner fork deformity is still persistent, but actually it is not causing her any grief at all. She is able to move and straighten the fingers without any problem at all. And there is a significant ability even in a youngster. This is a young teenager. You can see that epiphyseal growth plate is seen, and you can see that the fracture remodels very well, and you wouldn't identify that there was a fracture at all. So it remodels well. Sometimes you may need to fix it with an external fixator, but nowadays we don't like using external fixators that span a joint. It stiffens the joint considerably. And this is a volar button. Sometimes you may need to fix these with a plate and screw. So now we have locking plates, which means the head of the screw also has threads which can thread into the plate. So it keeps the whole device in a locked state. That may be the post-operative picture. The scaphoid fracture, as I said, it can cause avascular necrosis of the proximal part of the scaphoid, so we need to be careful. You can see here is a scaphoid fracture through and through. But immobilizing in a scaphoid cast, usually for 6 weeks, should make the fracture heal. Sometimes you may need longer. If it is a displaced fracture, then obviously you may need to put a screw across. So this is a Herbert screw or a similar screw, which you can see the threads here. It's a different pitch. The distance between the threads is different here compared to the threads here. So that's how it'll give compression once you're able to put it inside. Now, this is an interesting case where you have a patient fell off a motorbike and he's got wrist pain. You think actually it looks okay, but it doesn't look okay because this is a perilunate dislocation. You can see on the AP there is a radial styloid fracture. But on the lateral, if you see, the lunate is like this. The lunate should be here, and the moon shape of the lunate should be pointing up like this. But it has come off from there, and it is pointing volarward. So it's a perilunate dislocation. And now it has been reduced, and now it is in the right position. But the radial styloid fracture is still there. This is a fracture, just the proximal phalanx. Sometimes, you can treat it with buddy strapping, but sometimes you may need more intervention, like the small mini fragment plate. But fractures like this in the fifth is very common, and especially among young men after a fight or something, they may come with an injury like that. But at that point, we don't need to fix it. All what we need to know is whether there is any rotation of the fingers. So you ask the patient to point all the fingers together. If the nail bits are in a straight line, then you know there is no rotation of the fingers, and you can discharge the patient, ask them to mobilize. It doesn't need any splintage at all. So when you look, all the nail beds should be in a straight line, or when they make a fist, it should all point towards the scaphoid. All the lines will point to the scaphoid. Then you have all the fingers are in a straight way. But sometimes there may be rotation. In this case, there was a rotation and a plating was required. But majority of the hand fractures heal with non-intervention. But I want to say a quick word about draft. We have a lot of plates for the distal radius, but the draft trial was a very interesting trial. They did 461 patients across 18 centers, and they found that locking. So they were trialing between locking plate and KY fixation, and they found that the locking plate was not necessary. There was no difference between just KYs or locking plate. So just putting wires in is enough. This is just treated with a plaster, and this is treated with a wire. You can see how it keeps it stable, so you don't need a big plate. And there's this big trial which showed there was no difference. This is the Kapanji technique of doing the wires. A final word about osteoporosis. Now, this is normal bone on the left, and the bone on the right is osteoporotic bone. So that's quite high. 1 in 3 women will get it, 1 in 12 men will get it, but much less in men, more in women, and especially after menopause. But the ideal thing is we need to exercise and strengthen the bones. And osteoporosis fracture are in the spine, in the hip, and in the distal radius. These are mainly the effect. Now, this is how bone is. So the normal structure of the bone is collagen. Collagen is equivalent to steel. So in normal construction industry, you use steel, whether you're building a house, a school, or a factory. In the body, whether you build bone, anything you do, you need collagen. And once collagen is impregnated with hydroxyapatite, then it becomes bone. So you have adequate amount of collagen and hydroxyapatite, then it becomes normal bone. But when both the collagen and the hydroxyapatite decreases, that is when you have osteoporosis. But if you have osteomalacia, it's only the hydroxyapatitis decrease. So this is rickets, or what happens when you have lack of vitamin D, then you will have more collagen, and that's why you have bendy bones in rickets. So also on the top left, you can see normal bone. Osteoporosis, both the collagen and the hydroxyapatitis decrease, whereas in osteomalacia, there's more collagen, and hence that is why you have bendy bones. It doesn't break, it bends. And this is a study which showed that fracture of the wrist is the writing on the wall. Women who are at the 60s, they get a fracture of the wrist. It's important. What we tend to do is put a plaster and ignore them, but that is not. I think they require a clear education at that point when they have a fracture of the wrist. Yes, we can give vitamin D and calcium, but the important thing is they are becoming frail. A frailty fracture is a fracture that you get when you're standing on level ground and falling. Lots of women at the age of 60 fall and break their wrist, but that is the writing on the wall to say they are going to get a vertebral fracture or a hip fracture. If they exercise, we can actually prevent that. So the wrist fracture is because fracture begets fracture. So we should not ignore people who have a fractured wrist, and it is important that we are targeting them with increased weight bearing exercises, and so that their balance will get better and their osteoporosis treated by the weight bearing exercises. So a couple of points to remember. I don't expect you to be went through a lot of facts, but 5-6 facts very important. In a wrist splint, give a neutral splint. Don't give a splint. The usual splints are slightly in extension, but that will actually increase the carpal tunnel syndrome. It will not take away the carpal tunnel syndrome. So you need a neutral splint for carpal tunnel syndrome. Then we looked at the instability, how the wrist joint, the scaphoid, the lunate, and the triquetrum was like a seesaw. And if there was damage to this ligament, you will get a DISI. If you have a damage to this ligament, you will get a VISI, or the volar intercalated segmental instability, and that could cause arthritis. So it could be a wrist sprain, but it may lead to arthritis later on. We looked at arthritis of the hand, the osteoarthritis in the DIP and the PIP, the Herberdens and the Bouchard's node, whereas rheumatoid arthritis was mainly in the MCP, and we looked at the ulnar deviation. In Dupuytren's, if the patient is able to place a hand flat on the table, then you don't need any intervention. Only when they are not able to place flat on the table, we may need to consider some intervention. To examine the hands, easy way where the nervous system of the hand and the wrist is to do a rock, paper, scissors. Paper keeping the fingers straight, test your radial nerve. Rock making a fist, test your median nerve. Doing the scissor-like action is test the ulnar nerve, and if you testing the anterior interosseous nerve is to do the OK sign. And we looked at finger fractures. If you're able to get the same, all the fingers are pointing to the scaphoid or the nail beds, then no intervention is required. And we looked at how distal radial fractures was the writing on the wall, and patients with these injuries need to be counseled for doing exercises and improving their stability. Thank you so much. You can do feedback on this if you point, but let me do the